Good afternoon, ladies and gentlemen. It's my pleasure to welcome you to our autumn webinar that is dedicated to patients with multimorbidity. My invitation was accepted by my friend, Professor Jerzy Chudek, who will join us in a minute. And so we are going to tell you how to treat the patient with multimorbidity, but we are going to focus on patients with type 2 diabetes and chronic kidney failure. And we try to answer the question how to treat the patients safely. So I'll show you my presentation. We start with type 2 diabetes. I'll start with the dogma because we should all remember that patient with type 2 diabetes is always a patient with increased both cardiovascular and renal risk. The question is why? We should know that patients with type 2 diabetes suffer from heart failure, suffer from chronic kidney failure, and arteriovascular disease. And all these comorbidities generally may influence patients' life expectancy. If you take into consideration that approximately 50% of patients with diabetes has CKD, approximately 70% of patients with coronary artery disease has both type 2 diabetes and CKD, and approximately half of patients with type 2 diabetes has heart failure. You can know that's why they are at higher cardiovascular risk. And as I told you before, all the things together may influence patients' life expectancy. For example, patients with CKD stage 3 are 10 more likely to die due to any cause, but typically from cardiovascular reason, than to survive to be treated with renal replacement therapy. And if patient with type 2 diabetes has heart failure, so probably would die within 10 years. The over-mortality probability is at the level of 60 to 80%. Multimorbidity is defined as coexistence of at least two conditions. Here you have the data collected from almost 4 million patients in the United States. And in this slide, there's presenting the number of conditions ever recorded per individual. As you can see, the number of conditions increases with the age. So in patients age 70, there are at least 8 conditions. So that is why patients with diabetes, not only with diabetes, but older patients should be considered on the view not from the prism of one condition, but many conditions and many diseases. And that's true that was said by Arthur Bloomfield, that there are patients we can't help, but there are none we can't harm if we don't take into consideration multimorbidity. The question is, what can we expect in older patients? For sure, for polypharmacotherapy, that may increase the risk of drug interactions. If there is a decreased physical activity combined with blurred vision, may give you the increased risk of falls. And if patients suffer from depression, it of course influences patient compliance. If we discuss the therapeutic goal in patients with diabetes, I do believe that there are 2 golden rules. The first is that there are as many glycated hemoglobin targets as there are patients. So for each patient, the target should be individualized, carefully adjusted, just tailored. The other is that the intensive treatment should be reserved for patients who are relatively healthy. So in patients with intact cardiovascular system. You may ask why? Because in this group of patients with intact cardiovascular system, the risk of consequence of hypoglycemia is the lowest. But if the patient is older, if the vessels are already damaged, if we treat the patient very intensively, unfortunately, we may expose the patient to serious consequences. So it won't bring any improvement in cardiovascular risk. So what should we remember when treating the patient with diabetes and older age? So first of all, multimorbidity. You know from the previous slides that in patients age 70, they recognize at least 8 comorbidities. then therapeutic goals that should be tailored to individual patients, then dangers of polytherapy, and the meaning of possible drug interactions, and then pros and cons of novel treatment. What I do understand by novel treatment, so disease-modifying drugs, they are generally safe in older patients. They may prolong their lives and decrease the risk of MACE. But when talking about patients with in elderly group, you should remember about two major points. The first is to avoid complications, and especially hypoglycemia, and the other to achieve optimal quality of life during the treatment the patient is proposed. Here we have the patient and disease features that should be considered when we want to approach to therapeutic targets. So if the risk of hypoglycemia is low, if the diabetes is newly diagnosed, if the life expectancy is long, if there is no important comorbidities, no vascular complication, our approach should be more stringent. So the lower glycated hemoglobin, the better. But if the features towards the right, it suggests less stringent approach. So generally, we are talking about the less stringent approach because our patient is old. So older age, short life expectancy, long-standing disease, history of hypoglycemia, multimorbidity, and polypharmacotherapy suggest that our approach and therapeutic goal should be less stringent. Another question is if intensive treatment is beneficial and safe. To answer this question, we should go through the results of some selected studies. So based on ACCORD study, we know that very intensive treatment was associated with increase of both cardiovascular and all-cause mortality by almost 25% when compared to standard therapy. From the other studies, like ADVANCE and VALIDITY, these studies did not prove the beneficial effect of intensive treatment on macrovascular diseases. But on the other hand, the intensive treatment may reduce diabetic nephropathy by almost 20%. But on the other hand, and at the same time, the risk of cardiovascular adverse event was increased by almost 30 to 40%. So we should remember that the lower glycated hemoglobin, the higher risk of hypoglycemia. Here we have the age-related impairments of hypoawareness. So generally, older patients fail to perceive both autonomic and neuroglycopenic symptoms, and it results in less reaction time for corrective action. On the left side, you see the younger patients. So there is a gap between hypoglycemic awareness and onset of cognitive dysfunction. And thus the gap gives the younger patients time for correction, for drinking Coke, for eating some sweets. In older patients, there is no gap, and there is no time to make a correction. So that's why if the patient even have hypoglycemic awareness, the cognitive dysfunction starts immediately, and then the patient looks like a stroke and is transferred to ER with pseudo-stroke syndrome. And there's probably the answer, why is it so? Because glycemic threshold for secretion of contrarregulatory hormones is completely different from those found in younger patients. So you can see on the left when the glucose level goes down, first there is an inhibition of endogenous insulin secretion. And after that, there are secreted some hormones, some contrarregulatory hormones, like glucagon, epinephrine, growth hormone, or cortisol. That's the level for younger patients. But in older patients, the threshold is much lower, and it completely differs from that younger ones. And we should remember that severe hypoglycemia is a life-threatening condition, as it increases the risk of heart attack, stroke, or any macrovascular complication, approximately 5 times, 4 times, 3 times, respectively. So, as I told you, because there is a lack of time for regulators in older patients, then if the patient is unconscious, the patients are sent to ER with the recognition of stroke or epileptic. But it's not epilepsy, it's not a stroke, it's just neuroglycopenia, which could be reversed when the patient is provided with infusion of glucose intravenously. Another interesting point and very important is that the patient with or after episode of hypoglycemia have the very high risk of death, and the highest risk of death is recognized within 3 months after the episode of severe hypoglycemia. But let's do some practice. Here we have 3, I would say, different patients, but they are very similar. First, start with Joanna. Joanna is 70-year-old, she's a retired teacher, she lives alone, she was diagnosed with type 2 diabetes in the rest home, and she suffers from hypertension, rheumatoid arthritis, and heart failure. Alice is also a retired teacher. She is also 78 years old, but she lives with husband. She was newly diagnosed with type 2 diabetes, but she has no concomitant diseases. And finally, John. John is also 70 years old. He's also a retired teacher. He lives with his wife. He was diagnosed with type 2 diabetes when he was a heart attack, and he had previous stroke and 2 times TIA. So the same age, the same job, but completely different status condition. So my question is, what is the appropriate glycated hemoglobin target for all these 3 patients? What is Joanna, Alice, and John? To answer this question, we should look at standards of care in diabetes 2023. So if your patient is healthy, and if the patient has no coexisting chronic illnesses and has normal functional status, we should lower the glycemic goals, such as in a younger patient, so less than 7.5. But if your patient is older, if your patient has some coexisting chronic illness and there is some cognitive impairment, our treatment should be less stringent. So the glycemic goals is less than 8 or 8.5. So let's come back to our patient. I would suggest to choose for Joanna 8 up or 8.5. For Alice, who is newly diagnosed and has no concomitant diseases, should be treated as a healthy patient, so 6.5 to 7. And John, whose vessels are already damaged, previous stroke, TIA, and heart attack, so the therapeutic goal should be less stringent. So I would say 7.5 to 8. I would do like that. So that's my proposal. Another question is how to treat such a patient. Accept metformin, diet and life modification. What to choose? DPP-4 inhibitors, sulfonylurea, SGLT2 inhibitors, GLP-1 receptor agonist, insulin, or do nothing. So let's come back to our patients. Joanna, she lives alone. She has no support. She has heart failure. So we have to focus on risk of hypoglycemia and the risk of progression of heart failure. So I would choose either DPP-4, because this type of drugs is, of course, indifferent when we are talking about cardiovascular risk, but there is no risk of hypoglycemia. But the better solution is to use SGLT2 inhibitors, as this drug may decrease the risk of progression of heart failure and may probably prolong the Joanna's life. And of course, these kind of drugs are safe in the aspect of hypoglycemia. Or you can do nothing, stay like it is, without the risk of hypoglycemia and the less or more complicated treatment. What about Alice? Alice was newly diagnosed with type 2 diabetes and has no concomitant diseases. So if using DPP-4 inhibitors, you give her nothing except the lower risk of hypoglycemia. But DPP-4 inhibitors are not associated with decreased risk of MACE. But both SGLT2 inhibitors in GLP-1 receptor agonists may decrease the MACE, prolong the life, decrease the risk of kidney failure, and decrease the risk of stroke, and decrease the risk of heart insufficiency. So it's a better solution for Alice. And when talking about John has previous stroke, 2 times TIA, and of course heart attack. So we should use drugs that prolong his life and decrease the risk of MACE. And what to do? SGLT2 inhibitors or GLP-1? I would say both, because when talking about the stroke and TIA, you should remember that GLP-1 receptor agonists are preferred drugs because they decrease the risk of next stroke, and in a similar way, they decrease the risk of MACE. On the other hand, SGLT2 inhibitors are better in the aspect of heart insufficiency, heart failure, and of course, chronic kidney failure. So once again, what to pay attention to in older diabetic patients? So first of all, adequate education. So you should educate both patient and caregiver, for example, in the aspect of potential drug interaction or hypoglycemia. You should discuss about the eating habits, but it's rarely possible. If you have patients aged 80, it's almost impossible to change his or her eating habits. Then the physical activity that should be tailored to the patient, the higher physical activity, the better glycemic control. Then drug selection in the aspect of hypoglycemia and financial support. And you may ask patients or the caregiver if they have any difficulties with insulin devices, if insulin or GLP-1 are necessary to achieve the good therapeutic goal and glucose control. So let's talk a few words about pharmacotherapy. So let's start with oral drugs. I would say that polypills are the better solution because less is the better, and you have some combination, metformin plus SGLT2 inhibitors, metformin plus DPP-4 inhibitors. Then you have to discuss the risk of hypo. So better solution is metformin on DPP-4 than sulfonylurea. SGLT2 inhibitors and GLP-1 may prolong patient's life and decrease the risk of MACE. Then drug interactions, sulfonylurea. I would say that sulfonylurea is a group of drugs that shouldn't be used in older patients due to risk of hypoglycemia. And if the patient is patient with obesity, sulfonylureas may increase the patient's weight. Then easy-to-use regimens, once daily is better than twice or 3 times daily. The same situation like a polypills. And of course, costs, if patient can afford to buy older but better drugs. What about drug interactions? I told you that sulfonylurea is the worst possible solution, and then I'll give you some examples why is it so. There are some examples in the way how the sulfonylurea may increase the risk of hypoglycemia due to interactions. For example, allopurinol may reduce the excretion of sulfonylurea, the same increasing the risk of hypoglycemia. Warfarin or fibrates may displace sulfonylurea from binding to albumin. Warfarin may slow the metabolism of sulfonylurea. Non-steroidal anti-inflammatory drugs may increase the insulin secretion, and beta blockers may mask the symptoms of hypoglycemia. So please don't use, if it's possible, sulfonylurea in older patients and older patients with obesity. What about injectable therapies? Let's start with GLP-1 receptor agonists. They are safe. I'll show you in a moment. Once daily, so better compliance, and may influence the patient's cardiovascular risk. Look, in the group of patients over 65 years old, GLP-1 receptor agonists reduced major adverse cardiovascular events, cardiovascular death, the risk of stroke, and myocardial infarction. And when we talk about the risk of stroke, you should remember that the GLP-1 receptor agonist decreases the risk of stroke at the best way, that you can compare it with any other drugs, even with SGLT2 inhibitors. What's more about injectable therapies? So insulin. If your patient is intellectually fit and slim, you may use short-acting insulin just before meals or with meals. If your patient is intellectually fit but with obesity, you must start with long-acting insulin in the evening, and if it's necessary, you may use short-acting boluses with meals. But if your patient is with less intellectual capacity, you should work to just reduce the symptoms of hyperglycemia. You don't think about the precise glycemic target, just to fight the symptoms of hyperglycemia. Don't decrease the glucose level, because it could be not safe for the patient. Remember from ACOT study, the intensive treatment in the patient with damaged vessels was associated with increase of cardiovascular mortality by approximately 25%. When you use insulin, of course, analog insulin are better than human insulin. You have some comparison. When you compare glargine 100 versus human insulin, you of course improved not only glycated hemoglobin, but also you may reduce the risk of hypoglycemia, and not only the nocturnal one, but also the lower risk of hypoglycemia during the whole day. If you compare two different analog insulin, like glargine 300 versus glargine 100, you also reduce nocturnal hypoglycemia and hypoglycemia incidence at any time. The reduction is very, very good. So glargine 300 is characterized with the lowest risk of hypoglycemia in a very specific group of patients. What do I mean by specific? So on the left is a patient with chronic kidney failure, where the risk of hypoglycemia is higher than any other population, and the older patients we are talking about today. So the lowest risk of hypoglycemia during the insulin treatment is when you use glargine. It's lower than in the Gludec, glargine 100, and insulin detamir. So just to summarize, what should we think, or what should we do when you have older patient with type 2 diabetes? What to take into consideration? So first of all, individual therapeutic goal. It should be tailored to the patient, different in each patient. In a patient with small comorbidities, our approach should be less stringent. Then compliance and cooperation with the patient. So less pills is better. Once daily is better than twice daily. Once weekly is better than once daily. Then concomitant diseases. Remember, the older we are, the more comorbidities we have. If your patient is 70, the patient has at least 7 or 8 comorbidities at the same time. So if you focus only on one, the patient won't be healthy. Number of pills. Is really necessary to treat the patient with 17, 20 or pills. Polypills are better solution. You should focus on kidney function. The worse kidney function, the higher risk of death, the more damaged vessels. So the approach to therapeutic goal should be less stringent. Then side effects. So in the aspect of hypoglycemia, do not use, if necessary, sulfonylurea in patients with type 2 diabetes when the patient is over 65, 70 years old, due to higher risk of hypoglycemia and possible drug interactions. And of course, cost. If you give patient the best drugs, but the patient won't be able to buy it, he won't be treated in the proper way. But remember, what is the most important thing? The most important thing in the treatment of elder diabetic patients is to avoid hypoglycemia. And remember, there are some patients whom we cannot help, but there are none whom we cannot harm. Thank you very much for your attention. And please let me introduce Professor Jerzy Chudek, my best friend, who will talk about patient with multimorbidity, but Jerzy will focus on patient with chronic kidney failure. Jerzy, the floor is yours.
And I'm pleased to be to present my point of view concerning the kidney diseases in elderly patients. We are facing the problem of the global pandemic of chronic kidney disease, which is certainly partially explained by the definition. Currently, we define the chronic kidney disease and the kidney damage seen in the blood, urine, or imaging methods. And one of the most important is the albumin-creatinine ratio that is considered as significantly increased with the values greater than 70 milligrams per gram. All people with GFR below 60, that the decreased filtration is maintained for at least 3 months, is also considered as having kidney disease. And this is the problem, that our kidneys are aging as we are, and the same threshold for all the people is certainly not logical. In daily clinical practice, we are not measuring glomerular filtration rate, but we estimate the values using the most frequent equation. And since more than a decade, the recommended one equation is CKD-EPI. It is available, and we estimate the filtration rate based on sex, serum creatinine, and origin. But certainly, as I said, this is not the best way to use this definition for all the people, and certainly this already available definition overdiagnosed the chronic kidney disease, and especially in older people. Therefore, we urgently need an age-adapted threshold to define the disease. There is a broad agreement that abnormal urine excretion should trigger the diagnosis of chronic kidney disease, and there is no controversy concerning this. However, the current threshold for the general population for GFR, according to the established definition 60, is
Jerzy, mała prośba, włącz prezentację, czyli tam kliknij na cały ekran.
Cały ekran, ok.
Prawy dolny róg.
Lewy dolny róg?
Prawy dolny, tak byś miał prezentację. O.
This?
Tak.
Okay, sorry. And certainly this definition was based on the calculation performed for a large population coming from clinical studies, showing that the increased morbidity and mortality in the population start with the decline of the GFR below 60. However, the reanalysis I will show you in this moment are giving us argument to change the currently established definition of chronic kidney disease. And you can see on the right panel, the analysis was performed for 4 groups of patients, and this analysis was restricted to people without significant albuminuria. According to this arrows I show in this slide, you can see that the increase in the all mortality starts from the values below 75 for young adults, for the values below 60 for middle adults, and below 45 for the older adults. And this justified to change the definition currently available to decrease the GFR threshold to 45 milliliters, taking into account this data showing increased mortality below these values, and to reflect the problem of kidney aging. This certainly will decrease the overdiagnosis of chronic kidney disease based on only GFR in older adults without albuminuria. We have performed such analysis in the Polsenior study. It was a very large cross-sectional population-based study performed 10 years ago, and we have calculated the frequency of chronic kidney disease based on the established definition. And this study showed that the prevalence of chronic kidney disease is increasing from about more than 15% to more than 60% in the oldest. The largest part of chronic kidney disease was driven by the group 3A. It means that the group with glomerular filtration rate in the range of 45 to 60. And among this group, 79% of subjects did not present increased albumin to creatinine ratio. In a consequence, changing the definition from this largest part of people, of elderly people, we would not diagnose this chronic kidney disease based on the decreased GFR for the older population. So this age-adapted definition that probably appeared during the years that will come will influence the global pandemic and decrease this problem by about 50%, as much as 50% in older individuals. In consequence, these older people will not be referred to nephrologists, and the consequence for the healthcare system will be reduction of the unnecessary consultations performed in this group of subjects. As already Professor Holecki stated, chronic kidney disease usually is co-occurring with other diseases. And according to large population studies performed in Sweden in United Kingdom, we can see that less than 10% of people have isolated chronic kidney disease. And the frequency of this isolated disease is decreasing with the severity of chronic kidney disease. As in this presentation, you see that this prevalence is decreasing from about 15% for this group with moderately decreased GFR, with a high prevalence of people without truly chronic kidney disease, to only 2% in patients with severe chronic kidney disease with filtration below 15. The number of diseases, the multimorbidity, is also strictly related with the severity of chronic kidney disease, and the number of diseases is increasing with the severity of this disease. Many years ago, it was stated that chronic kidney disease is additional, not traditional risk factors for the mortality and morbidity, cardiovascular morbidity in the general population. But the reanalysis that were performed are clearly showing that in majority, this increased mortality and morbidity in patients with chronic kidney disease is just explained by the co-occurring chronic diseases of the cardiovascular system. I would like to state some words about the management of chronic kidney disease in the older adults. And certainly we have to take attention to coexisting diseases. Therefore, as also stated by Professor Holecki,
Jerzy, przepraszam, spróbuj kliknąć jeszcze raz tą prezentację na dole, bo ten się slajd jak gdyby zawiesił na 4. slajdzie, nie przychodzą ci slajdy, nie przeskakuje slajd. Na dole tę prezentację tego slajdu, tam i tak byś włączał prezentację.
Okej.
Tak. Bo tak by
to now it's good?
Nie jest na pełnym ekranie, nie jest pełnoekranowo, tak by się zawiesił ekran, wiesz? A teraz już jest 11 slajd, teraz jest OK, teraz jest 13, OK.
Is it okay? And I'm able to change it. Just a second. And this is changing, or it's staying on the same slide?
Yeah, it works. No, it works.
It works. Okay, I will try to pay it, and now we have the full screen. Okay, so I will take about few words about the management of the chronic kidney disease in older adults. And certainly we have to consider that we are dealing with patient multimorbidity, and we have to change the pharmacotherapy according to this coexisting diseases. So it's much more difficult to treat this group of patients. And this, which I would like to focus today, is the nephroprotection, because in the majority of
Nie zmienił się slajd, jest 13 cały czas. Klikaj po prostu może slajdy, te z boku, wiesz, a nie,
poczekaj,
nie przesuwało się. Okay.
Apply to Zoom. It should work. And now it's working?
Po prostu, tak, teraz się przesuwało.
Okay, so I'm still on this slide number 12, stressing that the therapy of chronic kidney disease in older population will be mostly restricted to some dietary intervention and nephroprotection. And very important point is that the therapy of patients with chronic kidney disease related to chronic glomerulonephritis has to be much less aggressive, as this group is at high risk of harm. As already stated, chronic kidney disease is coexisting with other diseases, and we can select some clusters. Chronic kidney disease frequently coexists with hypertension, obesity, and diabetes, with other diseases related to the atherosclerosis like ischemic heart disease, stroke, atrial fibrillation, but surprisingly, it also frequently coexists with pulmonary diseases, with liver diseases, and is present in patients with cancers. Concerning the management of patients with the diet, it is generally accepted that we are restricting the consumption of protein much stronger in patients without diabetes than in those with diabetes, and it is recommended to restrict the dietary protein to less than 0.6 gram per kilogram per day in patients without diabetes and below 0.8 in patients with diabetes. However, this therapy with the diet therapy should be changed in the oldest patients. We should tailor this therapy concerning the progression of chronic kidney disease. If we see the patients with relatively stable kidney disease without a quick progression, and this picture, clinical picture, then we see is dominated by the age, the already existing malnutrition and functional decline. In this patient, this restriction should not take place. But when we see the patient, which is relatively in a good clinical condition, which nutritional status is stable, and the progression of chronic kidney disease is significant, in this group of patients, the restriction of protein should take place. The second cornerstone of the therapy of chronic kidney disease is the restriction of sodium in the diet. However, the patients in elderly age, they are decreasing the intake of food, and certainly the consumption of salt is decreasing with age. We see on the left panel of the picture that the people with the sodium restriction in the older age have declined physical capacity and has increased risk of development of hyponatremia. So the quality of life in patients with hyponatremia in older age is certainly lower. On the right panel, we see the consumption of the sodium in middle-aged population in the United States. And we see that this consumption in the majority of citizens is between 2 to 5 grams of sodium per day. It's the most reasonable consumption is slightly about 2.3 grams in older adults. But modulating the consumption, we should take in mind that the consumption in older adults is certainly lower. So when we see the patient with initially low concentration of sodium, with previous episode of hyponatremia causing hospitalization or referral to specialist, we should not reduce the intake of sodium in this group of subjects. Therefore, this decreasing consumption of salt and prescription of drugs that are interfering with the regulation of sodium homeostasis, these drugs which are recommended in the therapy of hypertension, in the therapy of heart failure, including diuretics, angiotensin converting enzymes and blockers of angiotensin receptor, and finally also the diuretics, also sparing potassium, we should take in mind that this group of patients has increased risk of sodium depletion. And in many of the patients, we should start monitoring to prevent the occurrence of severe hyponatremia. And if we see the hyponatremia, we should consider the deprescription of drug, even they are recommended by guidelines, increase salt intake, and if necessary, reduce doses of drugs which are severely interfering with the sodium deposit. I will not put much attention today to the pharmacological nephroprotection because this is well-established part of the knowledge. We know from the recommendation of kidney disease improving global outcomes, so KDIGO, that among these drugs are those which are used in the therapy of hypertension and heart failure, already mentioned, also including sacubitril, that is recommended in patients with heart failure, already mentioned today, inhibitors of SLG2, and also finerenone, that is especially currently recommended in patients with chronic kidney disease and diabetes mellitus. Kidney function requires monitoring after initiation of this group, also to consider the changes of the doses and eventual deprescription. It is much wiser to start the therapy in older patients with moderate dose of these drugs, and then, if well tolerated and we see the improvement, to increase the doses. And certainly, using these drugs, we should take in mind that older people are at high risk of falls. So the therapy certainly should not cause symptomatic hypotension. The analysis of a large population of United Kingdom demonstrate the risk which are related to falls in older adults, and we see that orthostatic hypotension and polypharmacy and the use of loop diuretics are in list of these drugs that are increasing the risk of falls. It should trigger us to take the attention to the prevention of orthostatic hypotension and to minimize the number of drugs used in the therapy. We know that the benefits of the therapy of nephroprotection therapy is related to the time of this therapy. So certainly the best way is to start the treatment as early as possible and the patient which are very old will not benefit much from the therapy due to the short time of the treatment that left. According to the recommendation of the Cardiological European Society, this are informing us that we should take care of the monitoring of patients treated with drugs that are interfering with glomerular filtration rate. But the slow decline in the glomerular filtration rate up to 30% is acceptable. Certainly, the decline should not cause initiation of dialysis therapy, and many of these drugs can be used even in patients starting dialysis therapy. According to the lipid-lowering therapy, it is generally accepted that the therapy should be started early in patients with chronic kidney disease, already at the age of 50. And certainly, the benefit of this therapy is greater when this time of therapy is more than 1 or 2 decades. So in the elderly patients, it is well accepted that we will continue the therapy started before, but the question remains to be answered if there is any benefit to start the therapy with statins in the age of 80. We are dealing with the atrial fibrillation in patients with chronic kidney disease very frequently because chronic kidney disease is among factors that are increasing the risk of atrial fibrillation. And we know that according to the summary of product characteristic, we can use most of these new drugs which are not requiring monitoring of the consequences of therapy up to the stage 4 of chronic kidney disease. They are certainly contradicted in patients with mechanical prothetic valves, but in the majority of other patients, the benefit with this therapy, which are not requiring monitoring and usually is much safer in patients with chronic kidney disease. Probably during the next years, the trials that are started will show that the therapy with these new oral anticoagulants are much safer than the use of warfarin, that is the current standard in patients with severe chronic kidney disease. Patients with chronic kidney disease are suffering from the pain related to the chronic musculoskeletal diseases, which are very frequent in older adults, and this is estimated that more than 60% of older people have chronic pain that is the cause of the initiation of pharmacological treatment. Non-steroid anti-inflammatory drugs are not the best choice. We should be aware that these drugs are increasing cardiovascular risk, that this drug pharmacokinetics are changed in patients with chronic kidney disease. Therefore, if it is preferred to use the topical anesthetics, which are not interfering with the function of cardiovascular system. When we are choosing other drugs, we should be aware about the consequences of the therapy and the risk of falls and physical decline in this patient. So we should not use the drugs which are most strong and it's much better to use the short-acting non-steroid anti-inflammatory drugs in patients with chronic kidney disease. Coming to the conclusions, nephroprotection in chronic kidney disease. In patients with chronic kidney disease with multimorbidity is the cornerstone of the management. The dietitian intervention in older, especially sarcopenic patients, are much different than those in younger people, and we should not reduce in the very old patient the consumption of salt and protein, because the benefits of such modification of diet will not overweight the harm related to this intervention. Evidence-based guidelines certainly are very helpful to manage patients with chronic kidney disease, also in patients with multimorbidity, but certainly these guidelines will not solve all aspects that we'll face in daily clinical practice. Shared decision is the preferable model in patients management, and this sharing model will certainly improve the adherence and, in consequence, the efficacy of the treatment. The open question is whether artificial intelligence that are very rapidly innovating the management in medicine will be better than physician in tailoring the pharmacotherapy in patients with multimorbidity. Certainly, this artificial intelligence became better, and unfortunately, already this guidelines recommendation generated by the artificial intelligence is already better than a large part of physicians in daily clinical practice. Thank you for your attention.
Thank you very much. Thank you, Jerzy. Just two questions that we are asked. The first is, one is for me and one is for you. So let's start with the question about chronic kidney failure. The question is, what is the threshold of eGFR to diagnose a chronic kidney failure in older adults? Is it the same as in the younger or not?
According to this presentation, I hope it was clear. We probably should use 3 thresholds of filtration rate. For young people, the threshold should be higher than in the general in the current recommendation, as much as 75. For people middle age up to the age of 65, we should use the threshold of 60, and for the older, we should reduce the threshold to 45. But please note that that glomerular filtration rate is not the only criteria to diagnose the chronic kidney disease, and in addition, we should focus on the excretion of albumin, because increased albumin excretion, even in patients with good filtration rate, cause the diagnosis of chronic kidney disease, and patients with especially large excretion of albumin will benefit with the referral to the nephrologist, and if this diagnosis of chronic kidney disease is not clear, also with biopsy. It is very difficult to establish the age when kidney biopsy should not be performed, and certainly it should be also this decision should be also related to the functional status of the patient, because all the patients are a heterogeneous group, and the patient in the age of 70 is much different. They are much different, and in some of these patients, the kidney biopsy should certainly be performed to establish the diagnosis of specific kidney disease.
Thank you, Jerzy. And the other question is for me. So which drug use for type 2 diabetes with malnutrition? The answer is very simple. You should choose drugs that have no or minimal impacts on body weight. So either sulfonylurea, but I don't like this kind of drug, DDP4 inhibitors, and maybe SGLT2 inhibitors. But generally, both SGLT2 inhibitors and GLP-1 agonist receptors have strong impact, GLP-1 stronger on the body weight. So metformin, sulfonylureas, or DDP4 inhibitors. That's all the questions. So if there are no questions, thank you very much for your attention. It was nice to meet you this evening. Have a great time and a great evening. Thank you very much for your attention. See you next time.
Thank you very much.